So the other part of my job is not just patella surgery and knee surgery and knee surgery, patella surgery, and knee surgery. Is I'm a director of the Osteogenesis Imperfecta Clinic. So they have a big clinic in HSS in New York for people with brittle bones. They almost always, many of the patients have my cell phone. They almost always call me as soon as I leave New York, so I haven't had a phone call yet. But see, we have some very, very extreme cases of the bowing of osteogenesis imperfecta. And Dr. Fassier just retired, Dr. Montreal. And it's not just type 1 collagen disorders. It's a group of hereditary disorders that affects collagen synthesis. 85% are type 1 collagen defects, but not 100. Some have the blue sclera. I think most of you know the classic Silence classification. He's a pediatric orthopedic surgeon in Australia. Type 1's mild. Type 2 is basically kids are born basically not survive. Type 3 are the really short patients with severe deformity. Type 4 also have severe deformity, but not as bad as type 3 and not as short as the type 3. Type 4s could be pretty mild or pretty severe. And so the type 3 is about 20% of our clinic. And they have severe growth in height shortening. It's really the most severe type in our clinic because the type 2 kids don't make it to the clinic. And one of the reasons you can tell a type 3 and a type 4 patient apart is the type 3 patient never gets tall. They never get over 102 centimeters. But they have severe deformities. They don't always walk, even with surgery and bisphosphonates. They have the classic triangular face. They have terrible teeth. They have poor hearing because of the bones in their ear. Type 4s can look more phenotypically normal. There can be more mild cases or severe cases. But some of these kids have terrible, terrible fractures, and many of them will get surgical treatment of every long bone. And we usually can get these kids to walk pretty good, the type 4s. With type 3s, we do aggressive surgeries on, but we kind of do it for household walking or transfers to the wheelchair. They often don't become community ambulators. So when do we do this? In a young child with those severe deformities, we start to try to treat them after age 2, when they're getting strong enough to kind of pull up in the crib or try to cruise, try to stand. That's when we start thinking about the surgeries for the young kids that are type 3 or 4, or if they have fractures over and over. In the old school, we used just a solid nail. The old history was, and my senior partner, who I took over the clinic for, he would just use a rush rod. But as the femur grew, a lot of times these nails were causing trouble distally because they didn't grow with the patient. And so that led to growing rods. One of the first variations was the Bailey-DeBow rod that had a little cap on the end, but it required opening both joints. And that's no longer really used anymore. And then Dr. Fassier in Montreal developed this Fassier-Duval nail. So it has a thread on the top, a thread on the bottom, and the skinny male part and the outer part slides or telescopes after it. So it uses the power of the growth plate to expand. It's not a motorized, it just grabs on the epiphysis and it grows. Most of these patients require 2 to 3 osteotomies in their bones to get the straight nail in. So most of the time we're doing this open. Then once we get it straight, we put the skinny part in first. We go past the growth plate with the threads. And then we put the the outer portion in, and then the thread goes into the apophysis. If you haphazardly cut it and bend this tip, then it won't lengthen. So it has to be a precision cut without bending the inner part. Here's one of the first patients that I did with it. So my partner, my older partner, I put these in, starting to have pain and we're bowing. She's a type 4 OI patient. So I did, looks like 2 osteotomies. We don't want to put this thread past the greater trochanteric apophysis or it'll migrate in the bone. So you want to be in the apophysis but not beyond it. You can see how the epiphyseal portion is way past the growth plate here. And usually you could do a femur and a tibia on the same day without losing too much blood. But it's too much to do 2 femurs on the same day. It's too much. So 2006, 2007, 2008, 2009. And then eventually I even did her spine. A lot of the problem with these nails, you see how skinny her neck is? You see how she's getting acetabular protrusio? It puts a lot of stress on the neck. So even though I get these kids to walk and they're getting bisphosphonate medical treatment, they're getting a lot of therapy, a lot of bracing. Like this girl is a great walker. 25% of my patients in the clinic that I've treated with these nails end up getting a femoral neck fracture. So a huge rate. We're trying to figure out maybe a way to kind of prophylactically start treating that, but it's complicated because the kids are growing. And you know, if you put some sort of device up the neck and they're 5 years old, it's going to migrate out a few years later. So we don't have a great solution for that, but it's a common problem. I had my first patient with OI femoral neck fracture and AVN this year, you know, so that the fracture looked good treatment, but has AVN now. Here's a kid who's got a mild type 4, but a pretty big deformity in terms of the bowing. And both legs got the nailing. These still are pretty high, fussy operations. There's a 14% reoperation rate at 2 years, and it's about a 50% operation rate at 5 years. So it's pretty high. So even though we think the telescoping nails are better, they still have a significant complication rate. Timing, when they're begin to stand, we don't like using plates in OI. Plate fixation, the patients they break at the end of the plate. So we have to use these IM nails whenever possible. Of course, there's exceptions, but we try to avoid plating. And then we go slow with the rehab. Dr. Bostrom, who's off in the course chair here, in the course here, he's an innovative arthroplasty surgeon. He's helped me with many adult OI patients and done custom total hips or hemiarthroplasties. So they'll get a CAT scan, design the special prosthesis. When I see these kids in a clinic, or adults I see every 5 years, I get an MRI, because they're known to have basilar invagination. I'm operating on a kid next Monday, an adult next Monday, and the pediatricians or the medical team called me and said they have basilar invagination and they want neurosurgery to clear it before surgery. So it's something that we see and we look for. Another problem with these OI patients is severe coxavera. And these are hard to treat, but it's important to treat because we already know they have femoral neck fractures. And so Dr. Fassier developed this technique. You put in these K-wires, and then look where he puts the nail from the outside of the proximal fragment, outside, and rest the nail here. There's a case from his paper. Here's one of my cases. So it's a pretty bad small kid with coxavera. And it looks like, fussy surgery, but we were able to correct the coxavera. And then in the older patients, this is an adult with OI, you can find some small nails, locking nails. Of course, you could use a locking nail, but you have to really find the right one, like size-wise. You have to go to a pediatric size. This actually was a humeral nail that we used. So this is Dr. Fossier's 10 Commandments, Dr. Fossier slides. No rotting before walking age. Do not use an oscillating saw, is number 2. Don't try to jam it in there. If it feels like it's tight, either shorten the bone or do another osteotomy. Do not fight with OI bone. Do an osteotomy if you need to, and shorten the bone if the soft tissues feel too much. When you have a severe deformity like this, you don't try to do your osteotomy minimally invasive. Go ahead and look at the canal. Always consider an osteotomy, extra osteotomy. Your nail has to be perfect, and to do that, it's a straight nail. You need to make sure the bone is straight. This kid is bowing, right? So if you straighten the bone, they're going to be in equinus. So you have to know about the contractures of the hip, know about the contractions of the ankle. And usually in a young baby, you could address it with therapy, but in an older patient, you might have to do soft tissue lengthenings. We talked about the importance of making sure that this cut is perfect. A bent tip, it will not lengthen. This will get caught and stop to lengthen. On these severe bowings, when you get an x-ray, you think you're in the right spot, but you may be completely off. So you have to rely on your OR anatomy or move the machine more in this direction. But basically, you have to feel the greater troch and know that you're putting it in the right spot. Don't rely on your x-ray alone. And then Dr. Fossier's, it's teamwork. So we have medical, endocrinology, surgery, and our rehab. And so it's a fun group of patients to take care of. And since the routine use of bisphosphonates, almost all these patients are getting bisphosphonate treatment with the endocrinologist. They're all in special rehab, and they're pretty much all aggressively treated with these IM nails. A lot of the kids are walking in less pain, are stronger. So it's really revolutionized this group of patients and led to better function. So there you go. There's a little OI talk.